Muchas gracias. All right, so now we start this webinar. So today we have the honor to have Dr. Gentili, Fred Gentili. He's going to talk to us about the management of craniopharyngiomas. I will do a little introduction about himself. So this is our team. Dr. Patiño is the chief of our department. Dr. Arana and Dr. Soro are my colleagues, and we work in the Hospital of San Jose in Bogotá. So Dr. Gentili completed his medical training at the University of Toronto and completed his neurosurgery residency also at the University of Toronto, and completed also fellowships in skull-base surgery with Dr. Yasargil in the University of Zurich, and with Professor Simon in London in the National Hospital Queen Square. So Dr. Gentili is a pioneer on endoscopic and minimally invasive approaches for skull-base, and he has authored more than 120 publications and over 25 book chapters, and has numerous honors and awards during his career. Dr. Gentili is working right now as a full professor in the Division of Neurosurgery at Toronto Western Hospital in the University of Toronto, and is the chair in the Korean Houston in skull-base surgery, and is also chair, the Allen and Susan Hudson chair in neuro-oncology. So his main interests are on skull-base surgery, both open and minimally invasive endoscopic techniques, and pituitary surgery and gamma knife radiosurgery. So Dr. Gentili, welcome again. And thank you very much for accepting this invitation to our webinar. Please go ahead.
Thank you very much, Edgar. So I'll share my screen and make sure everyone can see my screen.
Yes, sir.
Everybody can see it? Great. So first of all, I want to thank you, Edgar, and your whole department for the kind invitation for me to give this this webinar. As you know, this is a new world, a new normal. These webinars I've given, I don't know, 7 or 8 in the last couple of weeks to all over the world. And so they're important. You know, we can't go to meetings, but at least this allows us to interact and give information. So it's very important. Colombia is a very, I like Colombia as a country. I've been to Colombia, I think 2 or 3 times, to Medellin several times. One of my former fellows was there, and then Cartagena, of course, a beautiful city. But I've never been to Bolivia, so to Bogotá, not Bolivia. I've never been to Bogotá, and I hope that this thing settles down so that maybe next summer with the World Congress there, that I'm, you know, that I'll come to see Bogotá, because I hear it's also a very beautiful city in the mountains, I guess. Anyways, so this is where I live. I'm in Canada. You know, Canada is the 2nd largest country in the world, and I live basically here in Toronto. Toronto is a beautiful city because it's a very multicultural city. From all over the world, immigrants come to Toronto. It's the biggest city in Canada, about 5 million people. I think the 5th largest city in North America. You know, and as I say, it's very beautiful. We have the CN Tower. It used to be the largest structure, but now I think it's passed by somebody in Dubai or something. They always make things bigger over there, you know. And then, as I say, a very modern city by the lake, one of the Great Lakes, the 5 Great Lakes is Lake Ontario. So I invite everyone, when all of this is over, to please visit us in Toronto and But don't come in January or February because it's very cold with the snow. So come in the spring. We have a beautiful spring and beautiful fall. So my talk today, as you can see here, is on the management of craniopharyngiomas, open versus endoscopic, state of the art. So, you know, meetings now, everybody likes the concept of versus, you know, it makes controversy, open versus, gamma knife versus this and versus that. And I think now at the beginning, it's very, you know, useful. It causes a lot of, excitement, controversy. But I think now, after a decade, it's almost, you know, over 10 years or more of endoscopic there, I think we have gone beyond the issue of versus against. And I think we are now really looking at the question of and, because we know that many tumors, but particularly craniopharyngiomas, that there's a need for both techniques, both endoscopic and open approaches, no question. And when you hear anybody say it must be done in this way, then you know that it's not true. However, I have to say, and I'll show you why, I believe that the endoscopic approach is superior most of the time. So that's it. I'll show you why I believe that's the case. So this is a famous, everybody has seen probably this before. People present this in their slides, that this is Carby Cushing 90 years ago, over 90 years ago, talking about craniopharyngioma as one of the most formidable of intracranial tumors and one of the most baffling problems that confront a neurosurgeon. This is 93 years ago. And this is a quotation from Fred Gentili in 1919 saying that craniopharyngioma still remain a significant surgical challenge and management problem confronting neurosurgery today. So that's what you have to say. It's still a problem for all of us. But why? Why is it such a problem? Well, first of all, craniopharyngiomas are not common. So, you know, if, you know, in pediatrics or whatever, but you don't see that many in your, you know, in your lifetime. You're lucky if you see one craniopharyngioma, you know, a year or so. So they're rare. They are benign tumors, WHO grade 1 tumors, but they can have very aggressive biological behavior and unpredictable behavior. You're not predictable. You can have a craniopharyngioma that, you know, that can be very indolent, and another one that can be very aggressive. They represent about 5% of all brain tumors, and they are very surgically challenging. Again, why? Well, because of their location. Their central location, as you can see, has very close proximity to the visual, optic nerve, and chiasm, the endocrine structures, the pituitary stalk and pituitary gland, hypothalamic structures, and vascular structures. And the interesting thing about craniopharyngioma is that they are not lethal. When you talk about, you know, a cancer or something, the long-term survival is actually quite high. If you follow these patients, over 90% of patients are alive after 10 years. However, there is significant morbidity and poor quality of life associated with the tumor, but also its treatment. And that is the key here that we'll see. Now, surgery still remains the primary form of treatment, but total removal remains very difficult. And if you go in the literature, you'll see some people say, you know, less than 50% can you really get a total removal. Some people say a little higher, but the total removal remains very difficult. And because of this, there's high recurrence rates. And some people would say, you know, up to 60%. Some people even say 90% of these, if you follow them long enough, not 2 years, it means nothing, you know, 5 years, 10 years, 20 years, that there's high recurrences of these. And the other thing that you will see that there's no guidelines, there's no consensus statement, there's no, if you go in the literature to say how do, you know, what is the management for this thing, you'll see that there's controversy and there's really no consensus of what the best treatment is for these. Now, epidemiology of these, we know that the incidence is very rare, as I said, 1.3 per 1 million people. They don't vary with gender or race. We know that they have a bimodal distribution. We all know that, you know, in pediatric surgeons, there's a peak during the childhood between about 5 and 15 years, and then there's a peak in adulthood, generally about from 60 to 75. With regard to pathology, we see that there are basically two types of craniopharyngiomas. There's they're all, as I said, WH grade 1. There's the adamantinomatous type, which is the great majority in childhood, and then the papillary, which is more common in adults, and they have a better prognosis. The adamantinomatous are a little bit more infiltrative and they occur in childhood. And pathology now, as you'll see at the end when I talk about it, has become a little more important, because as you see in terms of the molecular profiling of these, that there's some potential targeted therapies that may apply to one of the different types of meningiomas. Tumor characteristics, about 38% are generally cystic, 10% solid, but the great majority are mixed. And you all know when you see an MRI scan that they're generally combination. Now, the clinical presentation, obviously they vary according to size and the invasiveness of the tumor. The common presenting symptoms are, they can present with headaches, sometimes because of hydrocephalus. In children, growth arrests, and various hormonal disturbances, including they can present with hypopituitarism, including BI. Visual impairment, of course, is a very common presentation. And then cognitive issues, memory and other cognitive issues they can present that way. Obviously, when you see a patient, they need a full history and physical examination, examining all the issue of visual acuity, etc. Then I think it's very important in all our patients, as I'm telling you, all our patients undergo these things. So they need a full endocrine evaluation. And we always get our endocrinologist, and whoever deals with these should get an endocrinologist to see the patient and go over them very carefully, that they should assess their anterior pituitary functions, all the hormones, including growth hormone, IGF-1s, etc. And of course, electrolytes, serum, and urine osmolality, because these patients can have, sometimes you have DI, but sometimes there'll be a subtle DI, and then you ask them, they see that they're getting up 6 or 7 times a night to drink. And so they have already a early DI. Of course, they also need a full ophthalmological assessment, and we get them assessed by our ophthalmologist. Of course, fundoscopy is very important, visual acuity, visual fields. And now we have, of course, the ocular tomography, retinal cell fiber thickness. And we're learning that these are now important because they can be predictors. One of the things that we never are able to really predict, if it's, whether it's a meningioma with vision or cranial, will the patient get better? And obviously, the longer they have the vision, and of course, the less it's going to be. But now we have these more sophisticated that we've now understand, at least are starting to learn that based on the preoperative, we can at least tell the patient that there's, how much they can improve. Of course, if the patient has some cognitive issue, then a formal neuropsychological evaluation is important that you do preoperatively and postoperatively. And then, of course, the imaging, very critical. And in these, we always do a CT, CTA, MR, MRA. We want to look for calcification if the diagnosis sometimes is not careful. And then these will tell us determining the location of the tumor, the size, whether there's a cellular enlargement, and then the involvement, very important. That's why CTA or MRA of the vascular and neural structures. So this is very important in terms of, the examination that you do for any patient with suspected craniopharyngioma. There's a number of classification with regard to the of craniopharyngioma. This is the classical one from Kassan, and he based his on the pituitary stalk or infundibulum. So these were either pre-infundibular, trans-infundibular, or retro-infundibular. We also, one of my fellows also looked at another classification, and this is a fellow of mine from Egypt, looking at a new anatomical classification, looking at the criteria. So what we looked at was looking at the cellar, whether it was a prefixed or postfixed chiasm, the supracellar extension, whether it was medial, lateral to the clinoid, the paracellar, that looked into whether it went to the middle cranial fossa. And then based on this, we looked at what was the best approach, looking at either endoscopic, frontal, lateral, midline, and so forth. We're still looking at this. It's not 100%, but we hope that maybe eventually, based on this criteria, we can say, looking at that, yes, this is better for endoscopic, this is better for open. Now, what are the management options for craniopharyngioma? Well, obviously, as I said, surgery still remains the primary treatment, but we're seeing now the question of whether it should be radical surgery with a gross total removal at all cost, or a more subtotal removal, or what people talk about conservative function sparing, quality of life sparing type of surgery, as we're learning more and more of this. Then there's a whole conservative surgery with the installation of chemoradionucleotides. And now the current one is bleomycin has been used in the past, but now interferon alpha. These have not really, I think they've fallen a bit out of favor, except maybe in the pediatric group. In adults, we rarely use this. And then there's conservative surgery with various types of radiation, whether it's stereotactic radiation, fractionated or proton beam. Primary radiation therapy has been used for craniopharyngioma, certain types, small, whatever, that they have, primary therapy. And then more recently, as I have talked about, the question of targeted therapy, which I'll just touch upon. So what are the surgical approaches utilized for craniopharyngioma? And as you can see, of the open approaches, there's many, many, many approaches. You can see the bilateral approaches. There's a classical bifrontal, subfrontal approach, or at least bilateral. There's the bilateral transbasal and interhemispheric, which I like. For my open approach, my favorite approach is actually this one. Then there's the interhemispheric transcallosal approach, subtemporal approaches, combined superinferitorial approaches. And then there's a whole unilateral approaches that you can see, the classical pterional, the Asser-Gillian pterional craniotomy, and then with or without an osteotomy. And then now people, as you know, are talking about more and more the supraorbital mini craniotomy eyebrow approaches. So many open approaches. And now, of course, we have the transsphenoidal pure expanded endoscopic approach. So the goals of any surgery, of course, are to establish a diagnosis, decompress the affected neurovascular structures. If the problem is vision, the patient's going blind, you've got to basically deal with that. And then, of course, try to prevent it coming back. And by trying to get as gross total removal, if at all possible, because we know that would likely reduce the chances of recurrence. Now, there's a number of controversies in recurring pharyngioma that I'm going to go through today, and I hope this will shed some light on these issues. The first thing I'm going to look at is, what is the best surgical approach? Open, endoscopic. What is the best surgical strategy? In other words, radical gross total removal or subtotal resection plus radiation? And then this is the question that I asked to myself and others. Is it really possible to remove a craniopharyngioma totally and spare all pituitary function? That means you got a total removal and you spared all pituitary function. That means you spared the stalk. And I have my own prejudice here. I'll show you what my prejudice, and then we'll see if I'm right. And then don't have the time to look at the difference between pediatrics and adult, but then I want to conclude with the management of recurrent craniopharyngioma, because these are real problems. A primary one is a problem itself, but when you get a recurrent meningioma, very, very difficult. You do repeat surgery. What do you do? Radiation. When do you do the radiation? And then medical therapy and so forth. So let's start with the first one, which is what is the best surgical approach? And I think open or endoscopic. Well, this is over the last decade, as you can see, from 2008 2019, it's been my thing is that I've gone really to a long way over to the endoscopic approach. You can see the last 30 patients or so, both primary lesions and recurrent lesions, that if you look at what I've done, 2 craniotomy, 13 endoscopic, of this recurrent lesions, 9 endoscopic, 3. So really 4-to-1 towards the endoscopic approach. So the question then comes, of course, why? Why have I gone to this? Well, this is why I've gone to this. This is a 76-year-old gentleman. You can see pretty elderly, presenting with visual dysfunction, severe memory dysfunction, so cognitive, and some mild endocrine dysfunction with his lesion. You can see this lesion basically cellular, supracellular, mainly supracellular, retrochiasmatic, interpeduncular, has calcification, looks pretty much like a craniopharyngioma. So what approach? Open. Which one? Transmural. Well, this was presented 10 years ago, and about 10 years ago, everyone, and including myself, would of course have done this using an open approach. Which one? It depended on where you were trained or whatever, whether it was a terional approach, whether a subfrontal approach, interhemispheric, supraorbital approach, all of these. These are very good approaches. We all use them for other things, but there's a problem with these approaches for this type of tumor that I'm looking at here. And the problem is this: access. The access to this retrochiasmal interpeduncular is very limited. You have to work through the carotid optic space that doesn't exist here, either prechiasmatic, very small, and lamina terminalis. And these are all very, very, very limited space. And this patient was operated using a terional approach. And you can see after the, here we are, after the thing with the, running the endoscope, just to see, here's the lateral wall, but that's all we could do. You could not remove the superior part. You could not remove the part towards yourself. That's the problem with the terional, and the inferior part. So this patient, and you can see post-op, realized that we could not do it without harming the optic, and he had a large residual. And you can see, here it is, you can see the flare changes from the retraction. Now look at this, is the same patient. And then he had, first of all, had no change in his vision. It was a papillary cranial. So what do you do now? Repeat surgery, what approach? Radiation. Well, this patient then came to me, and this is now the endoscopic approach. And look at this approach compared to the other approach. It's like it's a different planet, you like to say. Here we are taking it off the medial wall of the hypothalamus on the left side. And it was stuck up to the chiasm that you can see here. And we're taking it off. Here we are looking at the fornix and the lateral ventricle. Here's after the removal. This patient was, I think they were higher, so we're not going to be. Here's the basilar artery. Here's the peak column that you see here after the removal. Now, as you can see, as I said, the aim was not to be so crazy and try to remove from the hypothalamus in somebody this age. So we left some to the wall of the hypothalamus, but he did compress his optic nerves and chiasm. He had improvement in his vision. He was pan-hypopid after, no CSF leak. 8 years later, he's stable. But you can see the difference in terms of the visualization that you get with the endoscopic approach. So there's no question in my mind that the endoscopic approach for craniopharyngioma has significant advantages. These lesions are generally midline lesions, and this is a midline approach. You get a very significant, excellent, wide, illuminated view of the anatomy. There's reduced manipulation of, as you saw there, in terms of the optic nerve and chiasm. You're not working over or underneath with those. And there's easier access to these retrochiasmal, interpeduncular, retrocellular parts of the tumor. Now, like any approach, you do not have, there's always advantages and disadvantages. And for the endoscopic approach, this is a very difficult, technically difficult approach, and we cannot minimize that. You're working through two nostrils, and there's a restricted approach and workspace that you need, training for. The whole issue of CSF leak and reconstruction with these large defects, well, as I'll show you later, we've made significant headways, but it's not been 100% solved yet. If people tell you it's solved, then again, it's not right. And then of course you need a learning curve for this. You cannot go to you cannot go to a course, one course, and do some anatomy on the course and then go back and remove craniopharyngioma. That's not possible. You need a lot of training in pituitary tumors first, etc. So this is my prerequisite for an expanded endoscopic skull base approach. for any pathology, whether it's a meningioma, whether it's a craniopharyngioma, etc. You need a knowledge of anatomy, because this is a different anatomy that you're doing now from below. It's a different anatomy from our anatomy from above. You need a very experienced interdisciplinary team of endoscopic surgeons. As a neurosurgeon, you have to become an endoscopic surgeon, but we also use our ENT rhinologists who are very expert in endoscopy. You need a bimanual, binostril technique, because we are basically microsurgical bimanual animals. We have to be able to do a microsurgical technique exactly the way you would do it under the microscope. Of course, we use all the issue intraoperative guidance, image guided ultrasound, of course, and then, of course, instrumentation. You cannot do these procedures without appropriate instrumentation, high definition cameras, screens, and et cetera, et cetera. And then, as I said here, there's a learning curve. You need training for these. And my recommendation is always that you need a fellowship training to do this. And this is our team, our skull-based team in Toronto. I think we have one of a very excellent team in Toronto, and you can see who they are. You know, we have head and neck surgeons that we do procedures with esthesioneuroblastoma, head and neck tumors, adenocarcinomas that we do together using open approaches, not necessarily endoscopic. And then we have also more recently more rhinologists. As you see, because of endoscopy has come in, so a lot more rhinology people that we do, and also otologists. But we realize that, you know, a skull-based team also needs, you know, radiation oncologists. Some of the cancers that we do, that, you know, we need these people, medical oncologists. Pathology is very important in making the right diagnosis in these. And of course, medical imaging, our residents and fellows are very important to us and the whole issue. So I'm privileged, and I think that we have a very excellent team in Toronto. We train many fellows from all over the world. Now, anatomy. And in fact, this is from my former fellow, João Dalmida. He's an excellent anatomical surgeon, and you can see the anatomy from below. And this is actually operative to show the operative thing. So this is what we're looking at. We're looking at this area here, and you can see it's limited. Here's the carotid prominence, the paracellular carotid. Here's the medial OCR, lateral OCR, the tuberculum, and the planum, the sella. So it's not like we've got a lot of space there. And then this is again with the bone removed, and here we are. Now, and then again, here we are, the sella, the pituitary gland. Here's the tuberculum, the limbus, and the planum. For craniopharyngioma generally, unlike planum, you don't need to do a significant planum removal, but we always do some, as you see here. And then the pathology is what you see here, basically. It's the chiasm that you can see here. Here's the tumor, the craniopharyngioma here. So I just want to show you now a removal, because people show slide, at least the videos, very quick video, and you see. And I think to show you how we do an endoscopic craniopharyngioma from start to finish. So here's the tumor. It's a large cystic tumor with some solid component. Okay, so here we go. And this is the middle turbinectomy. You can see here, this is the nasal septum. This is the lateral wall. So we always do a middle turbinectomy, and this gives us obviously good exposure, improved exposure. And then here now we see the Uncinate process, and then this is my ENT surgeon who is doing this part of the procedure. Does an uncinectomy. You can see, and you can see the maxillary sinus is over here. You can see it over here. Then the bulla, and this he's doing a shaver, using a shaver to remove the bulla, and then that takes us back basically into the anterior ethmoids that you see going into here. Now, after we do this, and I'm gonna just go here. Wait a minute, here we are. Here, okay, here. Okay, here now we're into the sphenoid, and we're opening up into the sphenoid. And the next, after we do this, is basically harvesting a nasal septal flap. Now you all hear about a nasal septal flap, how important this is. And particularly for these tumors, is very critical in the repair. We do a complex repair with a nasal septal flap as well as fascia lata. So the nasal septal flap, depending on the width, you can come, right to the floor as far over as here. If we need a wide flap, and you can come basically to the mucosal cutaneous junction if you need a very long one, sometimes that we need for a tuberculum meningioma or a olfactory groove meningioma. And here we are now taking superiorly. We try to avoid going up to the skull base, leaving a little bit of mucosa there for smell, but sometimes their smell, is definitely affected. Now let's go over, so I don't a lot of time. And here we are finishing that. Now we're harvesting the flap. As you can see, a very nice flap, and that's going to be basically for our subsequent closure. And then, here's now the sphenoid keel. And this is the same procedure we do, by the way, for a pituitary. Up to this stage, very similar we do here. Now we're going to cross to the other midline, and here's a sphenoid keel. Let me just go quickly over like this, and here we are. There's a sphenoid keel, and this is basically taking the flap on the other side. Now here we are at the drilling of the cellar, the sphenoid roof. You can see what we showed in the anatomy very nicely. Here's the paracellar carotids. Here's the tuberculum. Here's the planum, and here's the cella. And drilling all this down very carefully, and ultimately we go through, as you can see, to the dura. And now this is the dural removal. And then now, as I just again going a little bit further, and here we are. Now this is the gland, and here's the dura. And now we're gonna and you have to coagulate basically the anterior intercavernous sinus, which can bleed. And now looking in here, we can see already the optic chiasm. And here's the gland. We sometimes make a little incision into the gland here that allows us to go inferior. And you can do that, and it doesn't disturb the pituitary function. So here we are, and there's the tumor. There's your tumor. You can see the optic chiasm. So this looks like involving there. And this one had a very significant cyst, as you see. So as we go into it, we then open it, and we empty that cyst that we see here. And of course, there's tumor inside that is solid tumor that you can see here, and we continue to do that. And then using microsurgical technique, here's a solid component inside that we remove. Again, just carefully. Here's a typical machine oil type of material that you get in these craniopharyngiomas. And then carefully, and then we see looks like the stalk, if I'm not incorrect there, and we go here like this. There it is, pituitary stalk, the mammillary bodies, basilar artery, PCOM. There they are, mammillary bodies. So we took this out with the hope coming here and tried to spare the stalk, and this is after the removal. And in this, you can see the third ventricle, the capsule stuck all the way to the third ventricle. So to attempt in a 68-year-old to try to remove this capsule is really not a good idea, and you should not do it. So this was left. Here's the basilar artery. You can see very nicely, and then the reconstruction. Very important. We do it with a multi-layer. There's fascia lata inlay, Duragen. And then onlay fascia lata, we put one over the fascia lata. And then, of course, with that now, the nasal septal flap. You can see the beautiful nasal septal flap that covers that entire thing and allows us to do a nice removal. Okay, so this patient was pan-hypopit, despite our attempt to spare that pituitary. He was pan-hypopit, no CSF leak. He was improvement in his cognition, was able to be discharged in 7 days. The pathology was at an amptonomatus, which is interesting because he was an elderly person. Post-op, you can see he had still a bit of ventricular enlargement, but if you look at him at 3 months, significant improvement in his ventricle. He was cognitively back to normal now, but had some residual disease. You see, as you saw here, that we left trying to spare sort of the stalk. So what do we do now? This patient we observe, and this patient too is stable. But you have to keep very close observation, because there's a high risk for this patient that he could recur. So we watch him very carefully with serial MRI scans. What about this patient, 45-year-old? This is a cystic solid component, virtually blind, finger counting and one eye, 2800. So that, to me, that's virtually legally blind. Deficit, what approach? Well, to me, now there's no other approach than the endoscopic approach. And here we are now. Here's the approach that we do, the exposure I showed you in the other one very nicely. You can see it here very nicely. After removing it, again, here's the pituitary gland. And here, just to show you the importance of these vessels. You see these vessels here going to the chiasm? This is a superior apophyseal vessel. And it's very critical, because I think, people can have worsened vision after surgery. And to me, often I think it's more the vascular supply and not actually manipulation of that, So this approach gives us the opportunity to see these very, very clearly from below. It's not so easy to see this from above. Here, there's this patient, and this is true. It's not, I'm not making this up, because I could not believe it, from finger counting to 2020. And, sometimes you're lucky. And I think this is from 2200 to 2020. He, however, again, was pan-hypopit, including DVAVP, but this patient is 8 years, no evidence of these recurrence, but we're following every year. We keep following them in our pituitary clinic. And then I can go and show you, but I'm not going to do that. Another larger lesion, you can see here, all endoscopic, and nice removal of these lesions that you see using an endoscopic approach. However, there are limitations to the endoscopic approach, and I said it from the beginning. There still is a need for open approaches. So what are the limitations? Well, large tumors. This tumor you're not going to do endoscopically. This tumor you're definitely not going to go endoscopically. Lateral extensions, neurovascular encasement. If you see, around the carotid when it goes into multiple cranial fossa, purely intraventricular tumors. That is with the hypothalamic floor intact. It's not a good idea to open it through the endoscopic approach. And then, of course, surgeon experience, and the preference, depending on how comfortable you are with that approach. I'm just going to show you a couple. This patient is a 39-year-old young man with significant cognitive decline, as I say, and also visual dysfunction. So what is the best approach here? Well, some of my endoscopic colleagues may say, no, they will do it endoscopically. But for me, I did not feel it was a good one for endoscopy. Why? Well, look at, how significantly lateral it came, very narrow stalk, and then how superiorly, right to the third ventricle. So in fact, this patient, I did an open interhemispheric transcallosal approach, which I think was a safer approach in this case. And in fact, you can see we got a very nice removal of this approach. We came right down from here, all down here. The patient did well. He had some cognitive rehab that he required, and he was followed with serial MRI scans. But we did leave, as you can see right at the very bottom here, we left a little nubbin of tumor. And that's why I said you have to follow these very carefully, because 1 year later, what happened? A cystic recurrence of that area with, again, rapid visual decline. Now, what approach now? Well, to me now, there's no question that the best approach is the endoscopic approach. So we went back in from below. You can see very nicely the basilar artery. You can see the third ventricle, and we did remove that component there. This patient is now, I think, 5 years. You can see here, this is a fat showing no evidence of disease recurrence. And what about this 71-year-old lady? You might think, well, 71, that, this couldn't be done from below, but I was concerned about how far laterally it came here. So I did not do this endoscopically, and in fact, did this using a pterional approach. And here you can see between the optic nerve and carotid artery, we went lateral to this, evacuated the cyst. You can then put in a Ommaya reservoir if you want. This allowed us to remove some of the tumor here, but still some residual there. And finally, this one here, which is a lessons that we all learn. That 27-year-old, visual disturbance with this craniopharyngioma. So what is the best approach? Well, I was really, when we first started doing these, I said, now these are all going to be endoscopic approaches. And so I did an endoscopic approach, but this is what I encountered. I encountered basically the chiasm right in front of me. So in fact, this was a prefixed chiasm. And the only space that I had was about 5 millimeters between the pituitary and you can see even just this manipulation on the optic nerve. I really could not do very much in terms of removing it. And I was worried that I was going to make his vision even worse. And so why did it was my mistake. Look it up here now, very close relationship with regard to the MRI scan. You can see this is the optic chiasm, totally prefixed. So you can see there's really no space there. Generally, the optic nerves are pushed up and laterally, as you saw in these other ones. So this, to me, as I said before, is basically now a contraindication for endoscopic approach, is this prefixed chiasm. So this patient postoperatively, in fact, did worse. His vision was a little worse, just that little manipulation, and he was fully pan-hypopit. So then what do you do next? Well, I said, we should do this open. I would do an open approach. And he said, is there any other option? I said, well, yeah, you can do radiation, but you're young and so forth. Anyways, he did not want another open approach because of the vision had been worse. So whether he elected on radiation, he got IMRT radiation, 54 gray, 30 section. He's actually now about 4 years stable disease. So the radiation has stabilized. Okay, second one. What is the best surgical strategy? Radical gross total removal or subtotal removal? And radiation. Well, there's been a significant pendulum swing over the last decade or more, maybe 15 years, from a radical resection over to a more conservative function sparing and multimodality therapy. Now, why has that happened? Well, it's because of this. This is Yasser Gill's initial publication, 1990. He had about 140 patients, adults and pediatric. His complication rate was 86% of patients all had DI and hypopituitarism. 87 of them would permanent replacement therapy. And then the issue of postoperative obesity, up to 50% in pediatric patients, severe obesity, 40%. And then this was from Maurice Hsu. He's a very well-known pediatric neurosurgeon, looking at 138 patients in terms of recurrences, even after so-called radical. These are supposedly done very radically. The recurrence was up to 40%. The other issue was the issue of the mental disturbances in adults and children after surgery. And you can see that there was significant cognitive and social functioning in adults after removal of craniopharyngiomas. And you can see the issue of cognitive withdrawal, social problems, thought problems, attention problems, or morbid obesity. So all of these significant side effects brought neurosurgeons, particularly pediatric neurosurgeons, over to a more conservative approach. So from a radical excision as trying to cure that and prevent recurrences, but at a very significant cost to endocrine, hypothalamic, morbid obesity, neurocognitive decline, and poor quality of life, to a more conservative function sparing, to look at what the problem is. So if the problem is vision, deal with the vision and functional preservation and improvement quality of life. Now somebody will say, well, okay, that's fine, but are you going to have higher recurrences rates and with multiple procedures and radiation side effects? Well, it looks like that's not the case. Because if you look at these results in the literature, this is looking at progression-free survival and overall survival with regard to gross total removal plus subtotal removal radiation. You see that basically there's no significant difference. And in fact, in some of them, in terms of better outcome with the subtotal removal and radiation. And this also holds true for adults. The studies in adults also show this no significant difference from a radical gross removal to a subtotal with radiation. So I think it's very important. We have to be aware of this in our decision making. We can't ignore this in availability. So if you see a patient like this, 63 years of age, visual dysfunction, normal endocrine, what is the best approach? Well, to me, we did an endoscopic approach. And I'm not going to show you the thing because of time. Post-operative, however, he had some residual disease. What do you do with this? Well, we generally will observe, as I said before. So we watched him 3 years, had progression of his disease that you can see here. So you had radiation done 16, and now after the radiation, you can see now 4 years with a decrease in the size of the actual tumor. So this patient had, radiation therapy. And if you look at the long-term results of radiation therapy, and this is published on 14, looking at long-term survival, not long-term results. This is a 55 patient. You see the median follow-up was almost up to 276 months. That the local recurrence, long-term, at least the local recurrence was 95% at 5 years. I'm sorry, this was local control rate, not recurrent. Local control rate was 95% at 5 years, 92% at 10 years, and 88% even after 20 years. The overall survival was 10 years and 83%, and at 20 years, 67%. And no deaths were directly attributed to craniopharyngioma. 88%, 83 showed regression of the irradiation tumor, and in 7 total response. And interesting that 44 patients and none showed any significant deterioration during follow-up. Conclusion was there is relatively excellent long-term results in patients with recurrent craniopharyngioma after stereotactic radiosurgery. So we cannot ignore these results. Finally, is it possible to remove craniopharyngioma totally and spare pituitary function? As I said, my bias was that it was not possible because craniopharyngiomas arise from the stalk. So how can you remove it and then spare the stalk? But then with the endoscopic technique, I said maybe now that we were able to see better, that we can maybe spare the stalk, spare all function, and get a total removal. And this is just to show you a 54-year-old female that we large tumor here. I don't have time to show you the movie, but just that we were able to spare the stalk, but she still was at pan-hypopit. 1.5 years. The patient had a recurrence in the area of the pituitary stalk. And then we went back and did a total hypophysectomy that we see here. And then also this patient here. This is a patient with a suprasellar craniopharyngioma, smallish and very soft. So this, if anybody can, if anybody can remove this totally and spare the stalk, this would be one of the ones. It was a soft tumor. Look at that, very nice and soft, and it was very eccentric to the stalk. I'll show you just over here as we did the dissection, carefully, and there's the stalk over here. And as we remove it, took it off the stalk, and here we are. Look at that. So we got a total removal, and we spared the stalk. So I said, well, I guess maybe I was wrong. Maybe we can now remove the it all and spare the stalk if you have a nice tumor that allows that. So here he is. The patient did have an actual CSF leak, required a lumbar drain, but improved vision, as you can see here, transient DI, and normal pituitary function. So that was great. 3 years, looks great. So we cured him, right? No, 3.5 years. Here he is, increased visual dysfunction, and what happened? Here's the recurrence right in the region of the stalk, right in the region where we left the stalk. So what the best option? Well, we went in basically and did a total hypophysectomy, post-operative. You can see here after and he was pan-hypopit. So what is the answer to this? It's still the way I initially thought, that basically my feeling is that the answer in medicine, you can never say never, you can never say always, you have to, but I believe that it's rarely, if ever possible, that you can remove a tumor totally, a craniopharyngioma, and spare the stalk. And so you need patient engagement. So here's a patient, a young man with this, and now I tell the patient, I say, okay, I can do this, and I can go and remove it all, try to remove it all, but you're going to have total pan-hypopit, you're going to have to take medication, thyroid, cortisol, and for insipidus for the rest of your life. Or I can go and do improve your headaches and vision, but I may have to leave some, but there's a chance it could recur, but then we can use radiation. What do you want? And they tell you. This 27-year-old gentleman said, I do not want any possibility of recurrence. I don't care, take the stalk, take anything, but he had this incredible fear that this thing could come back. So to me, that was very good, very easy. I said, fine, okay. And so we basically went in, and again, because of time, I don't have a lot of time, but here we go. You can see the tumor. And then just to show you, there we are, there I am taking the stalk, because you're not gonna be able to remove this tumor and spare the stalk. So we then went on, and then just to very quickly to go on, I don't have a lot of time, our time is going, to show you after the total removal of the tumor. Here it is, here's the hypothalamus. And after the total removal, the basilar artery, you see very nicely. And this patient's post-op, 6 days, here he is post-op removed, but he's pan-hypopit. On the other hand, this is an elderly patient who didn't care. He said, no, I don't want to take pills at all. If you have to leave some, it's a benign tumor. You said you can do radiation. I don't want that. So for this patient, I was, I left some tumor. He had no hormonal replacement, but he had some residual, which will now follow. And if there's any evidence of recurrence, then we will do radiation. Finally, the management of recurrent craniopharyngiomas. And this, as I said before, is a real problem. And I think we all would like this patient. This is a patient that was referred to me from sick children, 23 years, I think 25 years for a craniopharyngioma that they operated on. You can see over here, 23 years later, they didn't do anything else, no recurrence. This is great. This is not common. More common or not, unfortunately, is that craniopharyngiomas do recur. And as I said before, they up to 60%. Some people even consider up to 100% if you follow them. They're a difficult management problem. Here's the median time to recurrence. The gross total removal rates are very low in craniopharyngiomas. Some people would suggest in reality less than probably 25%. And I'll show you our series of recurrent craniopharyngioma. The surgery itself is much more difficult. And the likelihood of you getting gross total removal rates a second time is very low. And these are the factors associated with recurrences. Of course, the degree of resection, the biology of the tumor, the adherence to the critical vascular structures. I showed you some of those in terms of the wall of the medial wall of the hypothalamus. If you can't remove it from there without causing major problems, it can recur. And then the duration of follow-up, which I told you is important. So it's a 52-year-old patient. And just to show you why do they recur? Here's a nice patient you can see is a cystic tumor. You say I should be able to go in, maybe remove that, but just look at what you find in a patient like this. So this is to show you. I'm going to take you all the way there because of you've seen this before now already. And now here we are after we cut the dura, and this is what we were faced with. There, look at. So what can you do with a tumor like this? It's stuck basically to the carotid artery, to the anterior cerebral arteries. You can see to the optic chiasm, optic nerves, and here's the pituitary stalk. So the ability to remove this totally is zero. Now, you can still do a good job, and as we've done here, as you can see here now, basically we actually were able to take this tumor off the optic nerve because as shown here, and I don't have a lot of time, just to go here, we were able to get the dissect it off here from the chiasm and off the stalk that you can see here, but I had no illusion that I'm going to get a total removal on this patient. So you have to be careful. So what's the use of then, giving her a total, hypophysectomy? Do it. So we took that off the stalk. You can see over here, but there's no way you're going to remove the capsule of the tumor that's up on the carotid. So this is after the removal. Let's just quickly go over there, and here we are after the removal. There we are. Okay, but this is obviously residual tumor. And here's this patient post-op. You can see the residual. What do we do with this now? So we observed it. Is this the right thing? or should we say it's, he's going to likely recur, should we radiate? My general feeling is that I do not radiate up front. I will watch carefully, and at the first sign, I will consider radiation. So the treatment option for recurrent are the same as we had for the primary open surgery, but I said carries a higher risk for morbidity and mortality, repeat surgery and radiation, and again, all of these. The only thing I can say is the treatment of recurrent craniopharyngioma often requires a multidisciplinary approach. Surgery itself is usually not the answer for recurrent craniopharyngiomas. So this is an 18-year-old gentleman. You can see here, large cystic tumor going up. What is the best approach? I did this open, this is a number of years ago, and I did this basically using an interhemispheric approach. Looking here, and this is the way we go. So it's really the same as the endoscopic, but from up front. And that's why I like the anterior approach, because it gives me access to both, and I don't manipulate the optic nerve and chiasm. And so here's the, through a lamina terminalis I did, and this is superior to the ACOM. So we were able to do it from above and from below. You can see the ACOM here. And we got a good removal. Look at here, we brought in the endoscope to show, but we could not get down here into this area here. And post-operative, of course, here's what we left. What do we do with this? Well, we watched it, observed it, but I go 1 year, again, decreased vision. And here we are. So what approach now? We went back in, did a transposition of pituitary, but just to let you know that transposition of pituitary means loss of all pituitary functions. So people say about transposing the pituitary, it doesn't work. The pituitary doesn't work after you transpose it. And it was very dense, very adherent. You can see here to the chiasm and hypothalamus. So we did really a subtotal removal. This patient underwent further recurrence, did a transventricular endoscopic EVD, and then finally IMRT radiation. And here he is now 2 years, it's 3 years now, with stable disease. And this is a patient who had a previous craniotomy and then radiation, now had a recurrence. So endoscopic is not, can be done even after craniotomy, but you have to understand that it's unlikely you're going to get a total removal because of the adherence, but you still can do it. And you can see here, looking inferiorly, we were able to get a nice removal of this tumor, not a total removal. And this patient is 5 years with postoperative stable disease. What about this patient? Well, what approach? Let's put the right frontal interhemispheric craniotomy that we can see here. And March 12, again, another craniotomy with our Maya reservoir. So it just goes to show you that, and I just don't have time, goes to show you that you sometimes need to do multiple procedures and multiple things. So let's look at some results, because I think I always say when I make presentations, very nice to show all those beautiful videos that you show and how great you are, but in the end, you have to show results. Result is important. So this is our series of expanded endoscopic, and it's just published just recently in February of last year, about a year ago, on a series of 43 patients that we did, at least 40 patients, I think, 43 patients, including recurrent cases. Here's the demographics you can see here. And the problem is you can see already 50% were recurrence. So you know that that's already a problem in doing. Here's how they presented. As I said, visual deterioration, headaches, the average tumor size you see here. So what was our results? Because this is important. The gross total removal was 44%, which I've told you. Most people is about less than 50%. But you have to understand this was 50% of these were recurrent tumors already that we had. Of the primary lesion, we were able to increase it to about 73%. And then when the objective, that means when because I'm an elderly person, your objective is not to go in there and do it, was to get a total removal, actually raise it up to 81%. But you have to be very specific in terms of what you do. The gross total removal rate in recurrent lesions was only 10%. And I think that's a valid, honest thing, because it's very difficult to get a total removal in recurrent lesions. However, the visual outcomes, and you can see, were actually quite encouraging, quite, satisfactory. 95% of vision was stable or improved with only one visual worsening. And the pituitary dysfunction, you can see still new DI in almost 42% there. And then mortality 0, CSF leak, 21%. When initially, Then with the use of our nasal septal flap, now we're less than 10%. But as I said before, it's not 100% solved. Medium follow-up, we did the initial follow-up 56 months. The recurrence rate was 14%. We then, for a variety of reasons, waited and followed the patients for an extended period up to 2015, 2 more years. And look at within 2 more years, 9 more recurrences. So the total recurrence rate was 35%. And that's why it's important, I think, if you ever look at series of whether it's meningiomas, whether craniopharyngioma, look at the follow-up. Because, you know, a 2-year follow-up, a 4 or 5-year follow-up really means nothing. You have to follow these patients longer, and you can see the recurrences. Now, this is looking at our recurrent adult meningioma. This was published back in 2016, from my former fellows. And this is what we found here. Basically, you can see they presented 69% had a symptomatic recurrence, and 13 had asymptomatic. Here's the average tumor size. And you can see the results. Average time to recurrence was, as you see, 3.6 years. The number of recurrences, some of them had 19, some of them had up to 6 recurrences. And it's interesting that about 80% required some further treatment, but 20% didn't. So it's interesting that some recurrences you don't necessarily. That's why you initially watch them and see if that they're progressing. And the treatment, of course, was everything from surgery alone to surgery plus radiation alone. And this is our gross tumor rates, as you see, very, very low, basically 19% gross tumor rates. Vision last follow-up improvement was about 52%. And the complication rates were a little higher. You see 11% CSF leak rates. 3 patients had a postoperative hematoma, required open procedure. But overall, the Karnofsky scores were about 80% at last follow-up. So I was going to show you a little bit of literature, but and there's many things in the literature. This was from Cavallo's group, and this is from a meta-analysis that was done by the Ted Schwartz group, and this is from the Pittsburgh group. And I just want to say that, and it's another large one. So if you have to, again, be very careful when you look at these meta-analyses, because they're often unreliable. And, when you're trying to compare apples and oranges, is a classical one, because you see that there's case selection bias. There's significantly greater numbers in the open, and longer follow-ups in one and the other. So we have to be very careful when we look at that. So what about a conclusion? I think I'm just over an hour. And this is based on evidence-based review. We only have, unfortunately, evidence of level C, at least grade of C, and recommendation level 4, because unfortunately the literature does not have any sort of randomized studies or anything. So my conclusion is basically these: that the management of craniopharyngiomas remain a significant surgical challenge, as I said from the beginning, regardless of the approach done. Craniopharyngioma should be considered a chronic disease, and this is important. So when you see somebody with craniopharyngioma, it's not somebody you're going to necessarily see and go away. You have to consider that a C, because I told you the survival rates of these are quite high, up to 20%, at least 80%, 85% at 20 years. And so the issue, because of this, that they're going to live a long time, we have to think about quality of life issue in long-term survivors. And I think there's no question, as I've shown you, that the endoscopic approach is a significantly addition and provides very, a complement to the transcranial procedures. And I think with careful patient selection, I think it's really the procedure of choice in the majority of craniopharyngioma, with less morbidity and higher rates of visual improvement. And there's no question we could not ignore radiation. And subtotal resective radiation is a valid strategy, especially in those cases where gross whole movement would carry significant risk to the patient's quality of life. So, no surgical approach. One approach is considered the best approach for all patients. Each patient is served by the formulation of a tailored, individualized surgical plan, taking into account both patient factors and tumor factors. Just very briefly, trends. And we all are aware of these now, the whole issue of targeted therapy, personalized medicine. As you know, this is the major thing. And these are some of the recent, maybe not that recent, in terms of molecular oncogenesis of craniopharyngiomas. and looking at a variety of pathways. And we know now the whole issue of the BRAF mutations that are found in the papillary pharyngioma, not the adamantomatous. And then considering getting targeted agents to target these pathways. And then you saw this in the literature showing this patient with a significant reduction. And so what has been our experience? We've had probably about 5 or 6 patients we've had so far. They're not that common. The 35-year-old patient, visual decline, had a craniotomy back in 2010, had radiation with a residual, had a repeat cranie in 2015, further recurrence, and then had an extended endoscopic approach that you can see here, and again, residual disease. What now? So this patient in 2019 had a residual growing. He was put on BRAF mutation, and you can see basically targeted therapy with dabrafenimid and temozidine. And here's this patient 6 months later with medication. Significant reduction. So there is a possibility. It's something that we have to keep in mind, and hopefully in the future we'll have more of this. Okay, so my final slide is the evaluation management of patients with pharyngioma regarding multidisciplinary team approach with the active participation of experienced surgical team, radiation medical oncologists, pathology, neuro-ophthalmology, endocrinology, and psychology. So thank you for your attention.
Thank you very much, Dr. Gentili, for your excellent presentation on craniopharyngiomas. So people is free to ask you questions on the chat, or if anyone want to talk, can raise their hands. I just have a couple questions. I will share my screen right now.
Yep.
Okay. So you were talking about the recurrence and the disturbance about endocrine function, and I had a chance to do this paper with Dr. Schwartz, and what we found is that probably it's really difficult to take out all the tumor without damaging the all the pathways. So even if you leave the stalk, is really hard to preserve the function, the pituitary function. So I don't know, is there any thought that probably there's a structural and a molecular damage over the stalk? I don't know. What I learned about this study is that probably the stalk is damaged, right? There is a complete damage. I don't know if the answer is that maybe, is there an option about taking, as you showed, to take all the stalk, and probably that's the main goal to avoid recurrence. I don't know. It's really complicated. So
it is, and as I think I told you, in the end, you have to decide. And my feeling now is, I've shown you from my experience, I do not believe you can remove, a craniopharyngioma totally and spare stalk function and pituitary function. So as I said, now I will talk to the patient preoperatively to talk about this. Before you don't say, I'm going to go in and remove it all. Yeah. The patient does not understand. What does that mean? You're going to remove it all? Okay, I'm going to remove it all, but you're going to be on you're going to be on medication. You're going to have to take medication. You're going to take cortisol, thyroid, testosterone. You're going to have to take DDAVP. So you have to understand that's what I'm going to do. And because we know that radiation plus subtotal resection has the same equal long-term results, that there is that other option that we have. And so to me, like I thought that one that I showed you there, if anyone could get a total removal, was that one. It just beautifully came off. It was soft. There was no thing, and you see, and that goes back to embryology. What is the, where does it arise from? Rathie's pouch, basically, the pouch that comes in. So the embryology is such that that is involved in the stalk. And so the ability to get every cell, every craniopharyngioma cell is going to be very difficult. And so to me, as I said, I go to the stage now where I look at it, see the age. If somebody's 75 versus somebody who's 35, and discuss it with them and make a decision about whether to be, how aggressive to be, and also the not just the stalk, but you saw the third ventricle. 2/3 of patients, particularly in children, whatever, have infiltration of the lateral walls of the ventricle, and you're not going to get a total removal of those without significant, hypothalamic morbidity with morbid obesity and so forth. So to me, that's not an option. So I'm not going to go after something that radical. Because in the end, I think if we think of this, as I tried to say at the beginning, as a chronic disease, it's a different concept, isn't it? We don't believe that, chronic disease are, osteoarthritis and so forth, and you come back. But this, as you see, you following this for 20 years. So, and you saw what I had to do in some of them, initial surgery, then, another surgery, then Ommaya reservoirs. So if you think of these as a chronic disease, you want to maintain quality of life. You don't want that patient that is going to be 20 years cognitively impaired, demented. To what end have you done, trying to get a total removal? So I think this is where we have to come. And as you know, in everything, the issue of quality of life matters. We can't ignore that in neurosurgery. When I was a resident, many, many years ago, I have to say, if we could get a patient off the table and he was alive, that was a success. Didn't matter. He was hemiplegic, he was cognitively impaired, but the patient survived. Now, over the last decades or more, we see the importance of quality of life issues, and you cannot ignore these. A patient that you've done, I don't care if you show a beautiful MRI scan that show no tumor. If that patient is demented, cognitively or hemiplegic, aphasic, that to me is a bad outcome. Yeah, and if you could have prevented that by being less radical, then you would have done the patient, I think, a better service.
Better life. Yeah, it makes no sense. I agree completely. I bring this this paper because when I was going through all the MRI studies of these patients, it was really difficult for me. I don't know, to differentiate exactly which cases were really, compromising the stalk, which were behind or not the chiasm. So I just, we describe this this classification, just where was the tumor, right? Because I think it's sometimes really difficult to know exactly, trying to predict if the patient is going to be on a hypopit completely or not, or because I don't know what's your thought about what can you do with the MRI to prepare your talk with the patient?
Yeah.
What are your goals in surgery?
Yeah. So Edgar, obviously careful observation of the MRI, going through it carefully. They try to do various sequences to see about, hypothalamic involvement. That's very important. If you see hypothalamic involvement preoperatively, that it's not going to be able to. But in the end, sometimes it's just not possible. You can go over it with your radiologist to take, hours saying, can you tell me, is it stuck to, to the hypothalamus or not? Sometimes you can't. You can't be, despite everything you can try, it's sometimes difficult to be certain. So you have to go back to the issue that I said, that, you can look at that and say, I think there's one that I may be able to get a good radical removal without significant compromise, or this one, definitely looks like I'm not going to be able to. Like the one I showed you that, had total involvement of the optic, and had things in the vessels. I didn't predict that preoperatively. I thought this is cystic. I think if it's a nice cystic thing, I'll be able to get the cyst off. You saw that. I was able to get it off the optic chiasm, but it was stuck to the carotid artery. It was stuck to the nerve. So sometimes you can't, as much as you want to get as much information preoperatively, and that's good. Sometimes you can't get all the information that you need.
Right. The last question I have, Dr. Gentili, is I've seen that some surgeons use the aspirator, like the Myriad device. I don't know if you have seen it.
The which?
The Myriad device.
What
It's
is that?
like it's like an aspirator, but it sucks like from the side, not with the tip. So yeah, because I have always felt that it's really risky, to put those aspirators within the cavity, even if it's that region is so risky, to have any neurovascular lesion.
Yeah, no, so far, touch bases, it's different. We've not had, as you saw in terms of the complication, no major neurovascular event that we had. We use suction, but our suction is very controlled. So, in this situation, you have different ways. Yasser had his own way of doing it, and Fukushima has a way to have very, very controlled suction. Absolutely, that's very, very important.
Yeah, thank you very much, Dr. Gentili. It's an honor for me to host you your presentation. I just want you to invite you again to the next WFNS that hopefully will take place here in Bogota next year.
Well, thank you very much for your invitation, and I'm hopeful, as I say, that this will all be over behind us, and we'll see you all in Bogota in next year. It's really August of next year.
Absolutely, Dr.
All right.
It's a pleasure. I will call you soon to talk about other things. Thank you very much. Appreciate it. Have a good night. Thank you.
Thank you all. Bye-bye now.
Bye.
Bye.